content, your last unit before your chapter or your last unit exam. There is a comprehensive final in this class. I'm not sure if you've looked that far ahead yet. But what we do is that last week before finals week, you'll have your Unit 4 exam, and then we'll do the ATI for this class. Remember we went to the computer lab, and we did that for pharmacology and fundamentals. This one is med surg. So anything you've learned this semester can potentially be on there. You have to have your assessment A and B done. That would be something else over these 10 days that I would probably get done, because you're not gonna wanna do assessment A and B the week before finals week. You're gonna be pretty busy with studying for this test, studying for comprehensive, that paper will be due. You don't wanna wait till all of it's due that week, or else you're gonna be stressed. So spend some time over break getting some of that stuff done. But with that, ATI will be, I think, that Wednesday, and then the following week is finals week. I always have that Monday of finals week as a study time with you to kind of go over what's on the final and maybe bring up old tests, whatever you feel like you want for that day. I usually do a tutoring session as a group. And then your final is scheduled as the university schedule that Friday. I'm going to request we do Wednesday. Is anyone opposed to that? Therefore, you'll be done with your classes that Wednesday. You won't have to sit around till Friday. I would suspect most of you are probably okay with it, but I have to let you know that because there should be no other class that conflicts with this time. But I would say most people don't want to sit around till Friday, and maybe I'm wrong. Okay, so let's just plan on the Wednesday of finals week will be the final here from 10 to noon. That'll be the day. And that Monday, I will do a review with you. So it's not required, that day is never required on campus for class, but I would suspect you probably want that for going into the final to see what you can prepare for.
That'll be at 10.
Yes, it'll be at 10 o'clock on that Wednesday. So after that, I will put grades in that afternoon, and you'll be done with this semester. ATI is done the week prior, so what I do with ATI is I have it due 1 week after you take it, so you have to do your remediation. So when you take your proctored ATI, I think it's that Wednesday, you'll have until the final to get the remediation done. What I'll probably end up doing is making it midnight, so if you wanna take your test, your final, and then go to your ATI in the afternoon, that's fine if you wanna do that. Most people just get it done right away, don't worry about it. I don't know what you have for leadership and nutrition. Is there just projects in there, I'm guessing, or do you have finals in those classes? No, so that should be the only thing you have. Okay. Any other questions? Housekeeping things. All right, so let's continue on. I think we talked briefly about, I'm just gonna go to the previous slide here so you can see, but we ended with some of the complications for liver. And those complications are gonna be more described at the end of this PowerPoint. So we kind of introduced what they are, some general treatments, and then at the end, when it talks about the nursing diagnoses or the interventions the nurse does, it's what you're gonna see for test questions. If you haven't realized so far, at the end of the semester, test questions come from those last PowerPoints because that's where the nurse actually does, or what they're supposed to do for that patient. We might have a terminology question on a test that says, what is this? But most of the time it wants to know, what are you gonna do about it? Or what is the nurse going to intervene and do for that patient? So we'll talk more about things we can do to prevent these issues or to monitor to make sure it doesn't get this advanced. So these are the things that you would see primarily on laboratory findings or assessment findings when you take care of a patient. So I want you, the whole point of really looking at a liver patient in these PowerPoints is so when you enter a room and you hear the report from the night nurse that says they have cirrhosis, I want you to think about what does the person look like? What kind of labs are you expecting to be high or low? And what kind of things would you have for cares during that day? In itself, that is a care plan. So care plans, yes, sometimes they can be tedious and long and you think they're kind of repetitive, but in general, all a care plan is thinking about, I'm taking care of a liver patient. Now, every time I take care of a liver patient, I'm gonna do those things again. So it's getting you in the habit of making another, part on your tool belt to be good about something. So I would say most people in this room have taken care of a patient with hypertension, right? Or someone that has high blood pressure. What kind of things you would do for them is what the next person you would do. Or if someone had diabetes and you had sliding scale insulin, those are interventions you're doing for that patient, so then next time you know how to do it. It's all part of kind of getting some experience. So for liver, renal failure can happen in later stages. It's not gonna be something that happens in the initial stages of cirrhosis. There are different stages of cirrhosis that can vary from months to years times. It's kind of like HIV. I like to bring up that because someone can have cirrhosis and it progresses to advanced in a year. Kind of like HIV, they can progress to AIDS very quickly. Some people stay in the HIV stage and never progress to an AIDS stage. It could be 20, 30 years. We think about people like Charlie Sheen, who has all this money, right? He has HIV. He probably will never get to a stage of AIDS because he has money to pay for medications to prevent him from getting to that stage. Same thing with cirrhosis. If they catch it early enough, it is very treatable, right? You still have some of that cirrhosis in the liver, but if it's not to the point of end stage, they can manage the situation, give medications, potentially even get to a point where put you on a liver transplant list, if that is the case. So with renal failure, this is probably an identification that says this is pretty bad. We've now got to a point where we're not going to return, we're not going to have that treatment, you're going to have issues with the kidney functioning. So what does azotemia mean? We've already talked about kidneys. Azotemia, something in the blood, not acid. It's more with what the urine and what your kidneys do. You're trying to excrete the toxins, right? So typically it's urea that gets back into your blood supply, or just the toxicities. When I think toxicities, I think about when you pee and it's urine, ammonia, that stuff is going right back into circulation because your kidneys have failed. So we all can imagine if we had essentially urine circulating through our body, high amounts of ammonia and high toxicities, that would cause you to have issues. They do retain sodium, however, if the person's retaining fluid, we may or may not have high sodium or low sodium levels. It all depends on, are they losing it in equal amounts, or are they retaining a lot of fluid? It can be both. So I don't want you on your test to be too married to sodium levels when it comes to what is the sodium, because it depends if they're dehydrated or if they're retaining fluid. Okay, so it depends on the person. What's the definition of oliguria? You want to know the actual definition, not just low urine? What is the definition of having oliguria? So how much in a day would be considered oliguria? Less than 100 is anuria. So if you make less than 100 mils in a day, that's anuria, meaning you do not make urine. It's 400. If you think back to, I don't know, patho, I've taught that there, farm, but 400 or less in a day is concerning with oliguria. That equates to roughly, is it like 16 mils an hour, 15 mils an hour? We know that's even half of what we're supposed to have. So by now you probably could spit out 30 mils an hour. That's exactly what we need to make for urine output. But consider that adequate amount of urine. I always compare urinary output to MAPS, or mean arterial pressures. What is an adequate mean arterial pressure? Remember back to MAPS. 60, right? But all that means is that if you're 59, you're gonna probably die, right? Or you're probably gonna have low perfusion where your organs are not gonna perfuse. Is 61 good? No, it's adequate. We would love to be 70 to 100. That's normal or good, right? Good is a term that we use kind of loosely in nursing because good to you means good to someone else different, right? So 60 for MAP is kind of the lowest you can have, but still have organ perfusion. 30 mils an hour of urine is the lowest we can have that your kidneys are being perfused. Is 31 good? No. 31 is adequate. See how adequate is different than good? Because good means that like you're having great perfusion, you're having great urine output. Everyone in this room, I guarantee if you watched your urine output for the day, it would be way more than 30 mils in an hour if you were to measure the entire day. And that's if you're adequately hydrated. Now I get there are days you don't have the best intake, but think of the days when you drank good water intake and fluids. It was definitely more than 30 mils an hour, okay? So oliguria is less than, oliguria is less than 400 mils in an hour, and that's when we get concerned with this problem. So at what point does a nurse go, okay, they have cirrhosis, now they have hepatorenal syndrome? It's not just one thing, it's kind of a combination of all the things. So what would probably happen first of all these things is they would start to decline in urine output. This is why eyes and nose are so important for really every aspect of hospital care, because it's the first thing to kind of happen where the nurse goes, yesterday they had 1,000 out, today they have 400. Now the next day they have 200 out in a day. See the trends of how it's getting worse. So most people will have more than that 400 mils in a day, for sure, and you'll start to see the decline, and that's when you start to say, maybe we should look at creatinine and BUN. Those are kidney function tests. If those are higher, you can start to develop the diagnosis of hepatorenal syndrome. Okay? So the hypotension here. So you're probably thinking, well, if they're retaining fluid, their blood pressure is going to be high. But keep in mind that these patients, if they retain fluid, where does the fluid go? Think of your big belly patients. This is not like your typical chronic kidney failure where they have adequate protein and the fluid is staying in the vessels. These people, again, don't judge me, okay, so their kidneys, right? If no pee is occurring, the fluid stays within, but it's going inside of their belly because of low protein. Remember, protein keeps it sucked into the vessel. So if my vessels normally look like this, and if someone that has low protein, you're gonna see this kind of become bigger, okay? Because all the fluid is just kind of leaking out of that space and you're not gonna have as much pressure. It's because of that low protein that you have high ascites, or high amounts of ascites. How do we know ascites is getting worse? We can look and be like, your belly's big. Next nurse goes, your belly's big. How do we know it was better yesterday or better today?
Did you measure their stomach?
You just have to measure it. Yeah, we literally get out like the measure that people use for measuring for tuxedos and dresses and such, and they measure on the belly. So if it's 50 inches, whatever it is, the next day it's 48 inches, or the next day it's 52. That's how they measure. So we measure around the belly button, or the biggest part of their belly is typically like, it's pretty uptunded. It looks pretty similar. But they measure on the biggest part, and then they will see the trends of difference, okay? So that girth around their belly. So, if the person results in an end-stage kidney, could they potentially have kidney failure on top of liver failure? Yes. And these people, once they get to this stage, it's pretty adamant that they get their liver transplant, or else this is not going to end well for them. So a lot of times they're on inpatient dialysis in the hospital because they're so sick, and then they potentially could die if they don't get this fixed. All right, spontaneous bacterial peritonitis. We talked about peritonitis with something in the past test. Do you remember what it was? There was something with peritonitis. So, what did you say? I can't hear you.
What treats it?
No. What do you, like, what was the condition or what was the thing we learned about in our last test that could cause this?
Dialysis.
Yeah, peritoneal dialysis, right? So if you have peritoneal dialysis and it goes into your cavity there, it's that mesentery area where you have kind of all of your stomach contents or your abdominal contents. But this is more related to the ascites that's stuck in this kind of space. And if it sits there where it's not supposed to be, it can accumulate infection. And these people are already immunocompromised because remember what the liver does. If it is kind of shunting blood to your spleen, killing off white blood cells, they have an increased risk for infection. So these people have large amounts of ascites, and what they do is they can suck this ascites or fluids off of the stomach and then test it. And that's essentially how they get the sample. And if you've ever watched a paracentesis, has anyone got to do that? I think there was someone in Parkson that got to do it. Abby, did you do it? Where they like took a needle, put it in the belly, and sucked it out?
Oh, it's in the lungs.
Say that again.
Mine was in the lungs.
Okay, so yours is more of a thoracentesis in the lungs, but paracentesis is inside the stomach. And so they pull off all this fluid, and then the goal is, yes, to take off a lot of fluid. But it's the same thing if you take a lot of fluid off the brain. You don't want to go too fast, and you don't want to take too much at one time. So sometimes what they do is they'll do this sample, and they get it off from their ascites, but they don't take off more than a certain amount, or else they could have pressure shifts in the body too. It'd be like losing, dialysis, doing dialysis in an hour versus 4 hours. You could cause fluid shifts and cause issues. So sometimes when they do a paracentesis, they go slow, or they only take off an X amount because they could have issues. So they try to go a lot slower. This is why people that have ascites, they get their paracentesis done, and you might look at them and go, you don't look that different. Your belly's still a bit. Why isn't your belly deflated? Because you can't take it all off. You would probably have like 20 liters of fluid on their stomach. So they might take 4 or 5 liters off today, a couple more days, let their body kind of regulate, take another 4 or 5 liters off. So they do it slowly. What do you think the treatment is for a spontaneous bacterial peritonitis? So bacterial peritonitis. Antibiotics, right. So we're not going to give something for a pathogen that's not correct. So we're not going to give antivirals to a bacterial peritonitis. It's a bacterial infection of that fluid. So we learned a little bit about our labs on Monday, but I want to kind of break apart what are all the things that you could maybe see on this test. probably been programmed to do this now for over a year, AST, ALT. I'm never gonna ask you what is a normal, I'm just gonna ask you, is it high or low or normal, right? So the most things you have to know for this test is high, but keep in mind that these are liver inflammation tests. So a person that has acute liver failure or liver issues that are more extreme, they're gonna be high in the meantime. But it's very closely related to something like troponin, when troponin looks at heart values. It's gonna be higher in the initial stages. As the person has a cirrhotic liver for years, they're gonna go back down to normal. So what I'll probably do for this test, for the simplicity of it, is probably make them elevated, okay? Just so you know that's liver function test. However, when you go out to practice, don't be alarmed if you have a cirrhosis patient and their AST and ALT are normal. And you're gonna say, why? They have liver cirrhosis. It's because they've had it for years. And your body regulates and goes back down and says, I'm not inflamed anymore. That scar tissue has now overtaken the liver cells and there's really no function there, okay? Which one of these, and I don't expect you to know this, but you're gonna learn it today, is high with alcohol, or usually is high more so with liver cirrhosis related to alcohol? Anyone know? So one of these is usually higher than the other when it comes to liver cirrhosis with alcoholism. Any guesses? You got a 50% chance. It's AST. This is good to know for this reason. If you have liver cirrhosis relating to hepatitis or fatty liver disease, your ALT is usually higher. If you have alcoholic cirrhosis, your AST is usually higher. So is that a good way, it's not 100% foolproof, but pretty good, to identify what the cause is? You have to obviously ask your patient, but it's still a good way to say, your AST is 3 times the amount of your ALT. I wonder if they're an alcoholic. It potentially could be the reason. So AST we look at more with alcoholism. So with liver function tests, yes, those are our main 2, but could these be elevated for other reasons? Yes. So we have to look further as to what does the liver do? What would be other labs that would say, since they're not making blank, it's going to cause this issue. So what was the one I talked about on Wednesday, or Monday? I think today's Friday. So, remember your fat soluble vitamins. Which one of these is most prominent for this problem? Okay, so vitamin K, sorry I have like really bad numbers. Vitamin K, a lot to do with clotting. If my clotting factor is gone, what's gonna be my problem? You're gonna bleed. So if my body's bleeding, I need to look at my H&H, my red blood cells, and platelets to see, and actually you can go as far as say PTI-NR. These are all the things you're looking for to suggest, is there a bleeding issue? Because if any of these are affected to cause bleeding, you're gonna have problems with your liver not producing vitamin K, which will result in all these things. So we would see all these are low. Why are coags high? I thought bleeding meant low. Your coagulation is how long your blood takes to clot. So if it's increased, it's saying that it's taking more seconds for your blood to clot. Is that a sign of bleeding? Yes. So PTI-NR and PTT are high because your body's taking more time for your blood to clot. These are because you actually are bleeding and losing blood. It's a lot to do with it. So those are the things we look for people that have liver cirrhosis, because once this happens, what is that telling me about their liver? It's pretty advanced, to the point where you're losing the components of what your liver does, okay? Another kind of sign too is looking at when I give a medication, is it staying in their body too long? Because if it's not metabolizing correctly or it's metabolizing slower, you could have issues with toxicities because it's not doing its job, okay? So metabolism could be affected with those meds. Then here comes your electrolytes. Everything is pretty much low when it comes to liver because it has a lot to do with how it regulates it and it can't communicate with your kidneys. And a lot of times if they have that leaking of fluid out into the ascites, your electrolytes go with it. So primarily the ascites has a big point with what that looks like. Bilirubin. What did I say about bilirubin and what you might have to know for your test? Anyone know what a normal bilirubin is? Like a total bilirubin? Any ideas? 1, okay? So, people that look jaundiced, their bilirubins are typically greater than 10. So I am gonna put a bilirubin on this test. I want you to know what high looks like. So if you know 1, I'm gonna put something that's high enough where you know that like, oh, that's bad, okay? So the person will, in return, if their bilirubin is high, look jaundiced. And bilirubin does not increase until end-stage liver disease. Or if you had an acute liver disease that was really bad, like it caused a lot of issues, you're going to see that at elevated level. So on your test for liver function test, it does not end at LFTs, like your AST and ALT. There's so much more to your liver than just AST and ALT. Okay, albumin levels. This would be part of a CMP. So what is the difference between a BMP and a CMP? One is basic, one is complete. So the complete is typically drawn in liver issues because the only difference between a BMP, basic metabolic panel, and a CMP is that the CMP looks at your liver. You probably don't have, I'm gonna put plus liver. You probably don't have a lot of patients in the hospital where a CMP is drawn. It's more the BMP. Because what are the things we look at in a BMP? Your electrolytes, your blood sugar, your kidneys. That in itself is your metabolic panel for basic. So you have all of those things in your CMP plus your liver function test. So we know that AST and ALT are gonna be on here. And they also look at your albumin, your protein level, your bilirubin. Okay, so these components are all directed at your liver. What would we suspect our albumin and our protein levels to be in a patient that has alcoholic cirrhosis and a lot of ascites? It's gonna be low, right? So they're going to have low protein. There's no fluid that can be sucked back into the plasma, so it just leaks out. The reason why they have low protein and albumin is because of diet, nutrition, malnutrition. These people do not eat. A true alcoholic does not eat. They drink all day. And I'm not saying that they never put something in their mouth, but they're more snackers. They might have a bite here and there, but they're not sitting down to a meal 3 times a day. They're drinking for supper, lunch, breakfast. Okay, ammonia. This is not something that's on your CMP. It has to be drawn by itself. So it's just a lab that you'll see kind of off on its own. But why do we draw ammonia labs for a liver cirrhosis? They are not getting rid of it usually. And ammonia, where we produce kind of that transformation between protein in the diet and they break it down into ammonia is how it actually happens. They are going to have that ammonia levels be high. We normally pee it out. But based on an end-cirrhotic liver, you're going to have problems urinating that ammonia out. So the only thing it does is it recirculates. So on this test, I'm not gonna put normals, I'm gonna put, is it normal or elevated? And you'll have to know what does it mean when you have an elevated ammonia level, okay? How do we test for it? By just looking at someone. I don't have my labs back yet, but I'm suspecting there's an elevated ammonia here. They're cognitive functioning. They have the mentality. I want you to think of a 2-year-old. Okay, what a 2-year-old acts like. And I'm not saying every 2-year-old, but I have one. I can tell that if she came in, it's very similar to an alcoholic cirrhosis. But that encephalopathy, that term in itself is because of high ammonia levels. It's like if you had pee that was supposed to go outside your kidneys and it's circulating up to your brain, you're gonna have that toxicity in that brain. So that's one, their cognitive status. And if I know they have a history of cirrhosis and now they're having cognitive issues, I go, I wonder what their ammonia levels are. Because those are heavily related. Then you could do an assessment. Remember the assessment we talked about? I have my flapping of the wrist. What was that called? Asterixis. If you haven't looked at a video of that, Google it later. But asterixis had that flapping of the wrist. Typically you see it more if you kind of push their arms back, but think about talking to a 2-year-old and saying, put your hands up like this, I'm gonna push them back. They'll be like, no you're not. Like, right? They're not gonna have that mentality to do it. So sometimes the labs do tell all. Glucose and cholesterol will be elevated. This is primarily because when the liver is cirrhotic, it doesn't accept insulin as good as it normally would. So you're gonna have high sugars. And then the cholesterol has to do with your liver liver produces HDL. What is HDL? It's a type of cholesterol, but is it the good or the bad? It's the good cholesterol. So if your liver is not functioning correctly and producing good cholesterol to eat your bad, you're going to have an elevated cholesterol level. You have to have function of your liver. This is why a lot of medications that help your cholesterol have to have a functioning liver to do so. Because if you don't, it's not going to work with your liver the way it should. And why would we do an abdominal ultrasound? What is an ultrasound? What does it do? Why is it relevant? Okay, not so much the fluid in the tummy, but it's looking at vessels. A lot of time the ultrasound will look at your organ, but specifically it can see the vessels and how it's moving. So remember, there was one reason why a lot of these things happen, like your ascites, your splenomegaly, portal hypertension. So hypertension of any vessel means constriction, right? You're gonna have that constriction of the vessel. Portal vein is the one it's referring to. The major vein that's inside your liver or bypasses the liver. If that is constricted and tight, you're gonna see shunting of blood to different areas. So you can see it shunted to the esophagus, that's why we get varices. You can shunt it to the spleen, which is gonna cause splenomegaly, that destruction of those cells. Shunt it to the colon, gonna cause hemorrhoids. And you can even have it shunted to the vessels that are gonna appear on your stomach. People that have true ascites, they get so full of fluid, it's almost like their skin is transparent. Like you can kind of see through it because it's like looking through pool water. And you can see the vessels kind of sitting on their skin, like we call them spider angiomas. They're like spider veins. We'll look at a picture on our break, but they look like really inflamed. So then we might have a scope that goes down your esophagus. So that scope that goes down, what is it doing? It's looking for something, right? It's a camera essentially. Robotics wise, it can go down and do things. But what is the first thing that they will actually see if there's an issue? Varices, right? Varices, if we think about how long our esophagus is, it starts at the back of our throat, right, our oral pharynx, goes down to the posterior part of our neck, and then think about where your stomach's at. That's where your esophagus ends. Where are the varices at in this whole passage right here? It's lower, right? It's almost to the point where it's right where the stomach begins at the bottom part of your esophagus. You're not gonna have varices up here. Okay, it's not going to be very high up in your esophagus. So what they do is they take this scope and they go slowly and gently, because what's the problem that could happen if they get too aggressive? You could make them bleed, and that would cause issues. If those bleed, they have a high chance of bleeding to death because of that pressure that's inside of there. And so it's like having an artery being cut open. Then you're going to have problems with hemorrhaging. So a lot of times we prevent it by not having foods that are sharp or trying not to cough or sneeze. People that potentially are, taking blood thinners, we gotta be very careful that this does not rupture and bleed. Liver biopsy, this is actually kind of an interesting thing too, but when we talk about cirrhosis, I can't say the word cirrhosis until we have a biopsy. It's the same thing with cancer. I can't say you have cancer until I have a biopsy of that cancer. When it goes as far as to tissue issues, I have to make sure I have a sample. Prostate, right? We can suspect things based on labs and vision, like a CT scan, but you can't say that word until you have the tissue itself. So cirrhosis, we might look at our labs, right? Or kind of our presentation. If the person has alcoholism, and now they're starting to have these labs, could we agree that they probably have cirrhosis? Yes, but I actually have to have that biopsy to confirm. So let's think about the biopsy, because there's one question on your board that 100% will be asked if it's a liver biopsy. It's like the only question you'll ever find out on Quizlets, books. If it has liver biopsy, this is the question. It gets asked every single time. So what part of our body is the liver? What side? Right, okay? So simple anatomy. We have to know, going into our boards, simple anatomy about what quadrants are gonna have what organs. So our right upper quadrant, we are going to take the sample, not you, a surgeon would do this, or a doctor, but they take the sample just like any other sample with a needle. They like puncture the liver, they suck out the contents, and they're trying to get a little piece of tissue. So they suck it out, but what comes with the NCLEX question is, what position do we put the patient in after a liver biopsy? And we wanna know what position and why. So think about if you had a bleeding forearm, it's bleeding. What are you gonna do? go on your right side, they're gonna put a dressing over top, but it's gonna put pressure on that liver to kind of make it clot off. So if we lay on our side, our right side, we can put the pressure on there to stop bleeding. So if that is the case, put them on their right side, and the reason why is to put pressure on the plates that they just took a sample from, and it's to prevent bleeding. So that just tells you that liver is a very vascular organ. If you don't do this, what is the risk? They will bleed. I just taught you what happens to their spleen. They already have low red blood cells, low platelets, low vitamin K. They have a high risk because of that issue too. So we're just trying to prevent more complications. They will not do liver biopsies until they have a appropriate PTINR and appropriate platelets. Because what if they are severely low with platelets and they already have a vitamin K that's not working, their PTINR is increased? We do not want to puncture someone's skin that's going to bleed to death, right? That's not helping anything. We can wait for the cirrhotic sample at a time where they're more adequate to get the sample. So we can assume the problem is liver cirrhosis. We don't need the sample right away if it's going to cause death if we get the sample. So always just keep that in mind, that whatever the risk, does it outweigh the benefit? Okay, so medication-wise, these next couple of slides, notice that none of these medications cure the problem. It just treats the symptoms that go with liver cirrhosis. So what is the only thing that would actually cure the problem? Liver biopsy, or liver transplant. So on this test, there's actually gonna be quite a few questions on liver transplant and who qualifies, what's the process, what are the complications. I think by this point, we've talked about transplant pretty often when it comes to heart, kidneys, all the above at the farm. We kind of at this point know some of the complications or the medications they're gonna be on indefinitely for the rest of their life. So the first one is diuretics. So obviously you can see why, but let's think about the complications with cirrhosis and why diuretics would be appropriate here. So the big bellies, right? The ascites that's in that stomach. So what's hard about diuretics is that it's not pulling, right? We're not pulling from that third space, and a lot of times the ascites is not in the vessel. There are times where you have some overload if they have like some kidney issues as well, but diuretics are good to a certain point, but they're not gonna suck the stuff back in there. So sometimes they do end up giving things that are more hypertonic, or they give them colloids to kind of suck that fluid back into the space. That is something they would do. And why are colloids such a good option for people with ascites? It has protein, right? Colloid is a protein, that's what it is. So if you put protein in your vascular space, it's gonna suck the fluid in, help your blood pressure, and then hopefully you'll be able to excrete it by your kidneys. With lactulose and neomycin, so neomycin is an antibiotic. It's still doing the same thing as lactulose though. So lactulose is not an antibiotic. How does lactulose work? We talked a little bit on Monday. Yep, it gets rid of the ammonia by pooping it out. So it basically kind of keeps the ammonia levels in check or lowers them. How do I know that lactulose is working? Yes, you have stools, that is something that will increase, but what's a better way to understand is it actually working? Your ammonia levels go down, your cognition improves. So if the person by the end of the day is more alert and oriented, they're not pulling their Foley out and all the above for consciousness, you know that the lactulose is working. This does not improve on its own. The medication has to be given. Neomycin is an antibiotic that kind of helps with the bacteria in the stomach to help you pass the ammonia better. So the reason why they give neomycin is to help with that ammonia level as well. So is one better than the other? No, they're giving together. The neomycin helps with the bacteria, so it passes better. Lactulose kind of gives it that extra push to actually make the stools improve. Okay, beta blockers. Oh, what happened to my screen? Must been getting bored with me. Right, beta blockers are gonna be more for that portal hypertension. So they typically give the beta blockers that are not so much your selective. So like metoprolol, that works just on the heart, they're gonna give more for the ones that work on the vessels, which are typically your non-selective beta blockers. So in return, if the vessels open up, it's gonna help not have as much pressure in that area and cause issues with that pulling of blood. So if a person has esophageal varices, they 100% are gonna be on a beta blocker. And if the person's heart rate and blood pressure are not that high, they have to be very careful with a dose that's good enough to get rid of the or to help the varices, but not make them hypotensive, which actually happens a lot where they're battling. We need this drug, but it's causing blood pressure issues. So they have a lot of problems with hypotension. You should know this already from our last test, but ferrous sulfate and folic acid are gonna treat the long-term effects of anemia, primarily because they are kind of having that loss of blood, but it's not the acute blood loss. If somebody has a hemoglobin of 5, folic acid and your iron are not going to do anything for your hemoglobin. It's for the people that are like 9 to 10, and it's just to help them not be lower long term. So they take it every single day. Antacids, these people tend to vomit a lot, and we also want to make sure that they're not vomiting anyway because they could have the varices. And so we typically give some of those just over-the-counter antacids for their stomach. This other medication, oxazepam, what does it end with that you've seen before? Pam, right? Pam has anxiety, right? That's how we remember in Farm. So this is one you probably haven't seen, and there's a reason why you haven't seen it. So this is not a typical medication, a benzodiazepine that we give people because the only time we give it is for poor liver function. Most people can tolerate a benzodiazepine, like lorazepam, very well, but lorazepam has a lot to do with the metabolism through the liver. This one does not have as much metabolism through the liver. So this is why they choose this drug, because it's not going to cause the liver to become more failed. So this one, why would we ever even give this? What is the cognition or issue with giving benzo? Why do we do it in liver failure? It has to do with those high ammonia levels. If they get really high, they get agitated, confused, crawling out of bed. So we might have to give something to calm them down so they're not causing safety concerns. Is this the first thing we do? No, but it reminds me of Adam's patient. He was very close. He had a patient in clinical that was like not even staying in bed anymore, walking the halls. To some degree it was fine, we had the time to do so, but what if this was going on 10 hours? We can't just have someone roaming the hallways. We're gonna have to maybe sedate them. Because, and I hate to say that, but it's a safety concern at this point, because he didn't want anyone to touch him. He might roam on out to the front door, right? So we have to be careful about safety. He didn't have liver problems, but just to mention. Okay, so what can we do for nutritional therapy? Now, protein is restricted only if the ammonia levels are high. And you need to really pay attention to that on this test, because in most cases, protein, we've always been taught, protein is good, protein is good. It's only when you get to stage 5 kidney disease and liver cirrhosis that you have to probably be careful with it, okay? So on this test, you're looking for, is the ammonia normal? Or if it doesn't say anything about ammonia, we probably could give some protein as long as the person's not having those end-stage liver findings. So if they have hepatic encephalopathy, ammonia is high, we're not giving protein in large amounts. Because what is protein broken down into the body? It gets broken down into urea, which gets broken down into ammonia. So the more protein they eat, the worse their encephalopathy gets, or their ammonia levels. Fluid restrictions. The more ascites they have, the more restrictions they're going to get, because it's going to leak into that peritoneal space. Why do they need high-calorie diets? And I'm not talking high-calorie of crap. Like, I'm not saying candy bars and all this high-calorie stuff, but like dense foods of high calorie. Because these people are not big eaters. So they might suggest very small meals, but high-calorie foods. So think of like your high-fat foods, or things that have a lot of dense calories in there. That is what these people need. They're gonna go from eating very little to needing to eat something to help their protein levels, or to help their problem. So some protein is good, a lot is bad. You don't want too much protein. What ends up happening is they probably get more synthetic protein, and that's gonna help with the fluid. What kind of vitamins and minerals would you suspect? Okay, but also A, D, and E, right? They don't make that fat soluble vitamins. So vitamin A, vitamin D, vitamin E, vitamin K. Okay, so when does the person get a transplant? You have to get to a point where you are end stage, but you're not too sick. You have to make sure you don't have alcohol in your system for how many months? 6 months. And you have to show your labs have been affected, right? So It's almost unfortunate sometimes, because people that have not quite severe enough, but they are pretty sick, they have to get to a lab point where, yep, we're showing decline in your liver. So the labs that we just discussed are going to be what they look for. Now, if you have any type of infection, you're not getting a liver transplant. And I'm talking about like MRSA or VRE, COVID. Those are things that have to be either cleared from the body, and they can take tests to see if they're cleared. But if you have that issue, they have to get rid of it. Another thing is cancer. So you can get a liver transplant if you have cancer, but it cannot be metastasized past the liver. So let's say they have liver cancer and it's just in the liver. It's a stage 1 or stage 2. We cannot have a liver transplant if it goes to the bones or it goes down to the pancreas or something. So liver cancers are okay to get a liver transplant, but what if this person is actively drinking as well? And they have to wait, let's say 6 months, right? So they are free of alcohol. What could happen in that time frame? Metastasis, right? So they could still be getting like chemo, radiation, but sometimes it's still metastasized, and that would not qualify them for a transplant. Poor surgical risk. This is not always the same as age, but it can be. So people over the age of 65 tend to not get a lot of liver transplants. However, you have those ideal 65-year-olds that are just perfect, right? They are 66 years old and they have no health conditions, great genetics, which I'm kind of thinking, why would they need a liver transplant, right? Like, who are these perfect people that need liver transplants? But let's say they get liver cancer and they try to get rid of it, they might potentially have a liver transplant in their future. So poor surgical risk would mean comorbidities. They have really bad diabetes, really bad hypertension, really bad heart failure. If they have all these things, they might say, you might get this transplant, but you're gonna live 6 months anyway because of all these other issues. Is this really the way you were supposed to do this? So we have to consider the person as a whole. Okay, why don't you guys take a quick break, and then this is, like I said, this is where a lot of your test questions will fall with when you actually have to